Assalamu alaikum. My case is Debakey type 2 dissection of the ascending aorta following the percutaneous coronary intervention, fighting in the Cath lab. No conflict of interest. The relevant history and physical examination and the test result of this patient reveal the patient is 46-year-old gentleman, hypertensive, non-diabetic, smoker, presented with ischemic chest pain for the 6 hours. Hemodynamic and the biochemical test, relevant tests are normal. Then ECG shows the old MI inferior, and echocardiography shows the inferior hypokinetic, and diagnosed as a case of old MI inferior, unstable angina, and hypertension. Coronary angiogram shows the there is mild disease in the mid part of LED and mild disease in the mid part of the OM1, and 99% stenosis in the proximal part of the PDA, and plan for the PCI to PDA. Then first we do the balloon dilatation of the proximal part of the PDA with 2 into 12 millimeter semi-compliant balloon, and we use the guide catheter is 6 French right Judkin, 3.5 curve Lancer catheter, and guide wire use the Terimur Anthro floppy PTC guide wire. And after pre-dilatation in the RCA, appears to be normal, but after implantation of the stent in the PDA, there is a dissection appears, pieces of dissection appears in the proximal and mid part of the RCA, and stent size is 2.25 into 30 millimeter, Zertolimus eluting stent. And after PDA stenting, dye held up in the ostium and dissection flap in the proximal part and flow compromise in the distal part of the RCA, and it also extend up to the ascending aorta. This dissection extend into the proximal in the ascending aorta, and then to prevent the extension of the dissection, we first deploy a stent 3.5 into 40 millimeter Serolimus eluting stent in the osteoproximal part of the RCA, a lateral second stent in the mid part, and after then we found that this dissection is almost disappear, except the lower flap is there, present here. And during PCI, unfortunately simple procedure may turn into the more complicated scenario involving the dissection of the whole RCA, including the ostium and the ascending aorta, creating Debakey type 2, that means only involve the ascending aorta. We took attempt to occlude the further retrograde extension into the ascending aorta by deploying the non-cover stent across the ostium. So good control of retrograde flow was obtained. And follow-up patient with the transesophageal echocardiography immediately after the procedure at 12 hours and 24 hours shows no evidence of the aortic regurgitation, pericardial effusion, and sealing of the aortic dissection. And my discussion point of this case is, what is the ideal way of treating the aortocoronary dissection, and have any role of imaging? Is there any evidence-based guideline to assist the operator in treating the catheter-induced aortocoronary dissection? How such catastrophe can be prevented? A take-home message is, aortocoronary dissection during PCI is a rare but life-threatening complication. Management of the dissection propagating to the ascending aorta is challenging. Rapid recognition is essential to employ the potential life-saving management technique in a temporary manner. From treatment with the conventional non-cover stent for the aortocoronary dissection may be life-saving. Thank you all.